everyone. A very good day to all of you. I'm Dr. Swati, one of your mentors in StudyMEDIC. So here we are again with another module. So in this series, we are basically discussing 10 SBAs and 10 EMQs, which are the most recent exam tested questions, especially of 2024. So proceeding further with the module that is early pregnancy. So as always, let's start with the quote. Consistency is what transforms average into excellence. So although you may not be able to do your excellent efforts every day, but still try to be consistent. Try to perform daily at least something or the other so that you can be consistent and achieve your results. So let's start with early pregnancy SBAs first. Ms. Priya Patel, a 34-year-old woman, undergoes a salpingotomy for the management of a tubal ectopic, diagnosed at 7 weeks. She is advised to attend follow-up appointments to monitor her serum HCG levels. So now what is the approximate incidence of residual trophoblastic tissue after a salpingotomy for ectopic pregnancy? So here, if we remember just few important percentages, we would be able to crack the correct answer. So as given in the GTG and NICE guidelines, the correct answer for this question is 20%. That is 1 in 5. Let's analyze the options. So residual trophoblastic tissue is observed in approximately 20% of cases following a salpingotomy for ectopic. What salpingotomy involves? It involves the removal of ectopic by making a cut on the tube and removing the contents and then either leaving behind or suturing back depending on the condition. But in this procedure, there is a risk of small amount of trophoblastic tissue remaining in the fallopian tube. So this residual tissue might sometimes lead to persistent HCG production, which then requires additional intervention, either in the form of medical intervention or repeat surgery. So this is the risk which is higher with salpingotomy as compared with salpingectomy. With salpingectomy, it's very rare. So if we look at other options, 1%, it significantly underestimates the risk. 5% is again lower than the actual incidence. Sometimes we might confuse with 1 in 5 with 5. But remember, 1 in 5 is 20%. So 5% and 10%, they are underestimations. 25% is a bit close to 20%, but 1 in 5, the exact percentage will be 20%. So here the answer will be 20%. So if we focus on the key learning points, approximately 1 in 5 patients undergoing salpingotomy will have residual trophoblastic tissue requiring follow-up and additional treatment. Serial HCG monitoring. In what way do we follow up patients after salpingotomy? We perform weekly serial beta HCG monitoring, right? Methotrexate is often used to manage the residual trophoblastic tissue if the patient is stable. In certain cases, when indicated, then surgical reintervention might be required, especially if the patient is hemodynamically unstable or if methotrexate has failed. And comprehensive post-op care and all are important. Coming to the second question, Mrs. Jane Williams, a 32-year, at 9 weeks of gestation, she presents with mild abdominal discomfort and slight vaginal spotting. A transvaginal ultrasound confirms a missed miscarriage. The patient is stable with no significant bleeding or signs of any infection. So what's the best initial management option? So for missed miscarriage, guys, it's very important to remember, a big shout out to all of you that now MIFI plus meso is the recommended medical management for missed miscarriage. One thing. Next thing is always first look whether expectant management can be done or not. Like for example, here it seems there are no contraindications for expectant management. She is stable. She's not having significant bleeding, plus she's not at risk of significant bleeding. Her pregnancy is also not much advanced. It's not late first trimester. So the best initial management option, we will look whether expectant management is there in the option or not. If it is there and no contraindications are there, we would prefer expectant management for 1 to 2 weeks as the initial, that is first line management option. What it involves? It involves allowing the body to naturally expel the pregnancy tissue without any medical or surgical intervention. It's the first line option for stable patients with a missed miscarriage in the first trimester. And it is appropriate for women who prefer a non-invasive option and are willing to wait for up to 2 weeks. Plus, she should not be at high risk of bleeding. She should not be having any bleeding disorder. Also, some of the indications which are mentioned in the NICE guideline are she should not have any past traumatic experience with her pregnancy. And also, she should not be in the late portion of her first trimester. After 10 weeks, we don't usually prefer expectant management. So success rates are especially high in early missed miscarriages. Medical would have been a valid option if expectant was declined or has been unsuccessful, or, as I told, in other cases where expectant is contraindicated. Repeat UPT after 3 weeks, this will be done after management, right? Vaginal meso, when medical is not mentioned, we won't go for that. Surgical evacuation would ideally not be the first line choice in stable cases, all right? So the key learning points, first line for stable patients without heavy bleeding or infection is expectant management. If she goes for medical management, then as I told earlier, please go search for MIFI plus meso in your options, not meso alone now. Surgical is reserved for cases in which patient is herself preferring surgical management, wants to get rid of the bleeding and all early, or if she's hemodynamically unstable, having heavy bleeding or infection. Always individualized approach involving patient in every decision-making is vital nowadays. As far as follow-up is concerned, ensure complete expulsion of pregnancy tissue by a clinical review or a UPT test after 3 weeks. Coming to the next question, Ms. Chloe Adams, a 30-year-old who underwent IUI, she presents at 8 weeks with severe abdominal pain and vaginal spotting. An urgent TVS reveals a single 8-week intrauterine pregnancy, along with a heterogeneous mass in left adnexa, 45 into 42 mm, along with free fluid in the pouch of Douglas. Now she is into early pregnancy. She is having red flag features, red flag clinical presentations like pain and vaginal spotting. But at the same time, intrauterine pregnancy is also visible, and adnexal mass, which seems to be ruptured ectopic, is also visible. So here, what is the most likely diagnosis which we should be cautious about? This comes out to be heterotopic pregnancy. Okay. So heterotopic pregnancy refers to the simultaneous occurrence of an intrauterine pregnancy as well as an ectopic pregnancy. It is rare but more commonly seen with ART like IUI or IVF. The adnexal mass represents the ectopic pregnancy while intrauterine pregnancy is the viable one. Here, when we look at the adnexal mass, then there is a suspicion of ectopic pregnancy since it's occurring in the background of abdominal pain and vaginal bleeding. Plus, the presence of free fluid in the pouch of Douglas still confirms our findings of ruptured ectopic. So here, it would require urgent management, especially in the form of surgery, because patient is having symptoms, she's having pain also, and her adnexal mass size is bigger than 35 mm. Analyzing other options, ovarian cyst may cause an adnexal mass, but it wouldn't explain free fluid in the pouch of Douglas or the clinical presentation. Ectopic alone can't coexist with a viable intrauterine, as in this case. Tubo-ovarian abscess, this typically occurs with PID, presents with fever, significant leukocytosis. So features like this are not described in the question. So tubo-ovarian abscess is excluded, and ovarian torsion can present with adnexal mass and severe pain, but usually won't be associated with intrauterine pregnancy or significant free fluid. So here, heterotopic pregnancy is the most probable diagnosis. So heterotopic is rare but more common with ARTs, presents with symptoms of ectopic. Ultrasound findings reveal both viable intrauterine and adnexal mass along with free fluid. Clinical features will be severe abdominal pain, spotting, and hemodynamic instability if ruptured. And it is especially common heterotopic pregnancy in pregnancies following assisted reproduction. So urgent surgical intervention here, as we discussed, because there are indications for surgical intervention. And while doing surgical intervention, we will try to preserve the intrauterine pregnancy. Here, if delay in diagnosis is made, then it might lead to life-threatening intra-abdominal hemorrhage. Coming to next question, a 35-year-old presents with history of 4 consecutive pregnancy losses. She previously had 2 healthy children with her former partner, but has been unable to sustain a pregnancy with her current partner. Her current miscarriages occurred in the first trimester. So what is the most appropriate investigation to evaluate the cause of her recurrent pregnancy losses? So here always we try to emphasize on the fact which is written in GTG that after third loss, on the third loss or more, try to perform the chromosomal analysis of products of conception if available. So first and foremost, we will try to do this. Immunohistochemistry of endometrium, karyotyping of current partner, no investigations needed, TSH, HbA1c, let's analyze why all these are incorrect. So first, chromosomal analysis of POC is essential, especially in cases where there is a history of healthy live births followed by consecutive losses. This would identify what? Things like aneuploidy, which are the most common cause of first trimester miscarriages. Also, it helps distinguish sporadic chromosomal abnormalities from the structural issues, which might guide further management. Immunohistochemistry of endometrium, as we have already seen in GTG, ESHRE, is never chosen as a first line investigation for RPL. It is only done in specific cases or in research context. Karyotyping of the current partner won't be chosen first. If suppose this option was not available, chromosomal analysis of POC, then obviously karyotyping would have come into picture. But in front of chromosomal analysis of POC, partner karyotyping is always secondary. If anything will be found in this in POC analysis, then we would go for karyotyping, especially of the new partner. So structural chromosomal arrangements like balanced translocations can be evaluated in the couple only if abnormalities are detected in the product of conception. No investigations needed, obviously. After 3 or more consecutive losses, we would need investigations. TSH and HbA1c, although hypothyroidism and diabetes are causes, but they are less likely in a patient with healthy previous pregnancies and so are not the most appropriate first step as of now. Here, chromosomal analysis of POC remains the single best answer. APLA are associated with recurrent losses, thrombophilia screening. These all are first-line investigations, only done in selected cases. Parental karyotype, looking for ultrasound, saline sonography, hysteroscopy to exclude uterine anomalies. This is especially relevant in the second trimester losses. Parental karyotyping will only come if some anomaly is found in the abnormality is found in the chromosomal analysis of products of conception. What management would be there? Genetic counseling, PIGT, these may be considered for future pregnancies. For APLA, low-dose aspirin and heparin are indicated. Coming to the next question, a 24-year-old sexually active woman presents to the emergency with a 2-day history of worsening lower abdominal pain and bloating. She has a history of recent completion of treatment of PID. Okay. On examination, she is hemodynamically stable, but has cervical motion tenderness, mild abdominal distension, and guarding. 2-day history of worsening lower abdominal pain and bloating, history of PID with these features, LMP 6 weeks ago, so immediately. But she reports no menstrual irregularities or contraceptive use. So first of all, initial step in her management, we have to rule out pregnancy first. So this is a simple one. But always, please don't get deviated by sexually active 24-year-old treatment for PID. So STD testing and all first. Always LMP 6 weeks ago, pain, cervical motion tenderness, do a UPT first. Don't straight away jump to TVS, but do a urine pregnancy test first. Because it is essential to exclude pregnancy first as the underlying cause of her symptoms. Conditions like ectopic or miscarriage can mimic PID and can present with abdominal pain, cervical motion tenderness, and distension. Failure to confirm the pregnancy status can result in mismanagement of potentially life-threatening conditions like ectopic. So always do a UPT first to exclude ectopic in such cases and then go on to have TVS. So STD testing will be a part of PID workup, but is right now not a priority in acute presentation like these. It can be performed after stabilizing the patient and ruling out these life-threatening conditions like ectopic. Antibiotics, they are vital in treating PID, but administering them without ruling out pregnancy could harm a fetus or delay necessary interventions for ectopic. TVS, again, it is very useful for diagnosing ectopic or DO abscess, but it should only be done once you confirm whether she is pregnant or not with a urine pregnancy test. Analgesia, reassurance, obviously these all will have a role here, but this is not definitive management. Symptomatic relief is supportive, but doesn't address the underlying cause. So this step should always follow the initial diagnostic workup. So pregnancy test first. Always remember, always rule out pregnancy, even in teenagers, even in POI patients, rule out pregnancy first if there is a history of amenorrhea or abnormal bleeding. So in reproductive age women presenting with abdominal or pelvic pain, regardless of menstrual history, rule out pregnancy first. Then ectopic pregnancy might overlap with PID symptoms. If PID is confirmed in a pregnant patient, you will have to modify the antibiotic regimen. These all are further key learning points, but here UPT first. Coming to the next question, among the following, select the strongest prognostic factor associated with recurrent miscarriages. So again, always whenever we go through the guideline of recurrent miscarriage, whether it was previous guideline or this guideline, maternal age is always mentioned as the first factor. So increasing maternal age has got the strongest prognostic factor. It's independent risk factor. The strongest independent risk factor for having further miscarriages due to any etiology are increasing maternal age and also the number of previous miscarriages. So we have got a table. In that, percentage is mentioned that at what age, what is the percentage of miscarriage. Also, increased paternal age is associated with miscarriage with 1.6 times the risk when comparing a paternal age of 40 to that of a 25 to 29-year-old man. Poorer prognostic outcome with increasing number of miscarriages has also been widely documented. Coming to the next question, what is the age-related risk of miscarriage in a woman who is 46 years old? So after 45, it shoots up to very high percentages and becomes more than or equal to 90% or more. So here the correct answer is very straightforward. Just we have to be aware of these percentages. It's the least in 20 to 24 years. After 35, it rises very rapidly. 35 to 40, it's 25%. 40 to 45, it's 50%. And more than 45, it's more than 90%. Okay, so these percentages have been repeatedly asked. Please keep them on your fingertips. Next SBA, Mrs. AB, 29 years, is seen at the recurrent pregnancy clinic after having 4 losses in early pregnancy. All her tests are normal and she has 1 child from previous relationship. How do we proceed in her case? So this question is again correlated to the previous question which we dealt with. But here, karyotyping of products of conception or chromosomal analysis of products of conception is nowhere mentioned. So here the best option will be karyotyping of male partner. But please do remember this will always come after chromosomal analysis of products of conception if available. In approximately 2 to 5% of couples with recurrent miscarriage, one of the partners carries a balanced structural chromosomal anomaly. Most commonly, a balanced reciprocal or Robertsonian translocation. So although the carriers of such kinds of translocation are phenotypically normal, but their pregnancies might be at increased risk of miscarriage. So the risk of miscarriage is influenced by the size and genetic content of the rearranged chromosomal segments. Hence, it is essential that we first carry out chromosomal analysis on products of conception. If not available, then obviously karyotyping of partner or parents, whatever the option. 19 years old student during her studies gets pregnant. She has plans for her future to achieve. She will ruin her future if she will carry on her pregnancy. She's concerned about this. Her partner is not serious too. So she is requesting an abortion on social ground. Under which clause will it fall, or under which clause will you abort? So this is actually the commonest indication for termination of pregnancy in UK, and this falls under clause C. Please do remember, clause C is the commonest clause under which maximum abortions take place. These are the clauses. You should be very, very well aware of them. In A, the continuance involves risk to the life of pregnant woman, but not in an emergency situation. If in an emergency situation, it becomes F. In B, termination is necessary to prevent grave permanent injury to physical or mental health of the woman. If in emergency, example rape and all, then it becomes G. C is the commonest one. It can be implied anywhere, like continuance would involve risk greater than if it were terminated of injury to the physical or mental health of the pregnant woman. Here, conditions like these, where student is getting pregnant, can't continue her studies, or where contraception has failed, then also mental health of the pregnant woman would be at risk. So clause C is the commonest one which is applied. In D, there will be injury to the physical or mental health of any existing children of the family. Means other children, the lady won't be able to take care of her other existing children. So if she's aborting on basis of that, then it will be D. If the lady is aborting on the basis that if the child would be born, it might be seriously physically or mentally handicapped. So that's why let's abort it here. Then it would fall under. So this is the summary of the statutory grounds. Coming to the last SBA, Miss Susie, 32-year-old at 13 plus 4 weeks gestation. She is 41 years, wants screening for Downs, which is the most appropriate test at this gestation. Since she is 11 to 13 plus 6 weeks, all we know is that the best test at this time is combined test. Combined test means maternal age, NT, PAPE, and beta-HCG. So if she would have been between 15 to 20 weeks, then triple or quadruple test would have been the best. If suppose she booked late or NT was not possible because of some reason, then at this point of time, you will offer her triple or quadruple test. If she comes positive on screening, then you have to have rapid access to appropriate counseling. You will have to refer her to fetal medicine specialist. Also, routine anomaly scan as such should not be routinely used for Down syndrome screening. All right, so now let's start with the EMQs part. Let's come to the first EMQ. For each of the women described below, we have to choose from the option list the single most appropriate diagnosis or treatment. You are the specialist registrar on call for gynae and have been asked for advice on a patient who underwent investigations earlier today. She is a 28-year-old woman who is 6 weeks pregnant by dates, complaining of pain lower abdomen. A UPT is positive. Ultrasound and blood tests are given to us. Uterus is retroverted and normal on ultrasound. No gestational sac or yolk sac is seen in the cavity. Both ovaries are normal with no adnexal masses, no cervical excitation or adnexal tenderness. The beta-HCG on the day of scan is for 5:45, and then it is repeated 48 hours later and also 96 hours later. The values are with us 680 and 991. Now repeat USG is now showing uterus retroverted and normal, no gestational sac or yolk sac in the cavity again. Both ovaries visualized and normal with no adnexal masses. So now we don't have any pregnancy tissue visible in the first scan or the second scan. Also, there are no signs which are suggestive of pregnancy tissue anywhere. So this is clearly falling in the diagnosis of pregnancy of unknown location. So the correct answer is G, pregnancy of unknown location. What we generally do in such cases, take two serum beta HCG measurements as near as possible to 48 hours apart, as we have seen in this case. And then we can predict as to in which direction this pregnancy is going. Like suppose if the rise is more than 63%, it's likely to be an intrauterine pregnancy. So we can offer her repeat TVS between 7 to 14 days. Fall is more than 50%. If in case, then it is unlikely to continue. So we will ask her to repeat UPT after 14 days. So depending on the beta HCG values as to where they are going, we decide as to what to do. If they are asking you about the diagnosis, you can point the diagnosis as in here. If they are asking you about the treatment, then depending on this, we can go on to choose the further treatment which we will. Like depending on the gradation of beta HCG here, like beta HCG is going in which direction, then we can decide. If the rise is more than 63%, which is not the case here, then we will repeat TVS between 7 to 14 days. Fall is more than 50%, then we will ask her to repeat UPT after 14 days. If it, in case it is between these, then we will refer her in view of ectopic pregnancy. Okay, so we will proceed according to this flowchart in all cases of pregnancy of unknown location. Coming to the next question. You are the specialist registrar on call for gynae and have been asked for advice on a patient who underwent investigations earlier today. Again, similar to above question. She is a 28-year, 6 weeks pregnant by dates, complaining of persistent pain lower abdomen. A urine pregnancy test is positive. Ultrasound and blood test results are as follows. Uterus retroverted and normal. No gestational sac or yolk sac within the uterine cavity, both ovaries visualized and normal with no adnexal masses, no cervical excitation or adnexal tenderness. Beta HCG again was done on the day of scan, repeated 48 hours later, came out to be 680 and 1320. Okay. Now repeat ultrasound shows you uterus retroverted and normal. No gestational sac or yolk sac seen within the uterine cavity. Both ovaries visualized and normal with a small left adnexal mass. Here now, repeat USG shows small left adnexal mass and significant free fluid in the pouch of Douglas. So this is very much suggestive of ruptured ectopic pregnancy because the way the beta HCG has the direction in which this is going and also the left adnexal mass and free fluid in the pouch of Douglas. This points towards the diagnosis of ruptured ectopic. So when carrying out a transabdominal or transvaginal scan in early pregnancy, look for a moderate to large amount of free fluid also, which might represent hemoperitoneum. If we look at the other findings, which is usually found in ectopic, as we all know, the most common finding is adnexal mass. It may move separate, it will move separate to the ovary. That is sliding sign. Comprising a gestational sac containing a yolk sac, or comprising a gestational sac and a fetal pole, or it would be empty gestational sac, which is often referred to as tubal ring or Bajel sign. Most common is this, complex inhomogeneous adnexal mass. This is the most common ultrasound finding. Also, look for an empty uterus. Sometimes you might find a pseudo sac. So all these ultrasound signs are suggestive of ectopic pregnancy. Coming to the third question, a 25-year-old who is 7 weeks by date self-refers to EPU due to history of previous left ectopic treated with methotrexate. Now in this ultrasound shows a gestational sac of 30 mm with CRL of 6 mm intrauterine. No fetal heart action is noted. The ovaries and adnexa are normal. So now at CRL of 6 mm, CRL of 6 mm means fetal pole is there, but no heartbeat is there. Since it is less than 7 mm, we can't be sure. So if we can't be sure, we ask her to repeat TVS in a week. So right now, it falls under the category of pregnancy of unknown viability. So in any case, if you are unable to locate heartbeat, go for CRL. If CRL is less than 7 mm with TVS, no visible heartbeat, place her in the category of pregnancy of unknown viability and ask her to come after 1 week before making final diagnosis. If she is 7 mm or more with on TVS and she is not having visible heartbeat, then you can go for either of the two. Either seek a second opinion on the viability or perform a second scan 7 days after the first one. So this should be your approach. Next, a 34-year-old nulliparous woman with history of recurrent miscarriage is admitted with vaginal bleeding. Successive scans carried out on previous visits had shown a missed miscarriage at 12 weeks. She suffers from poorly controlled bronchial asthma as well. So now missed miscarriage at such an advanced gestation, that is late first trimester, warrants for medical management. Yes, we already discussed this. Expectant would be first line if she was less than 10 weeks. She is 12 weeks, so expectant will not be very safe for her in view of her high risk of bleeding. So the correct answer is medical management, and that again is MIFI followed by meso. She is 12 weeks, liable to heavy bleeding, so expectant treatment is not ideal. Okay. So use expectant as first line and explore options other than expectant management if she is at increased risk of hemorrhage, like she is in late first trimester here, or previous adverse or traumatic experience like previous stillbirth, miscarriage, or APH. Here again, this is also present, history of recurrent miscarriage. So here 2 factors are present which contraindicate expectant management. Late first trimester also, and previous history of recurrent miscarriage also. Also, she might be at increased risk from effects of hemorrhage, like suppose if she's having coagulopathy, unable to have blood transfusion, then also you won't offer her expectant management. And lastly, in the case of infection, avoid expectant management, okay? So for expectant medical management, we offer a 200 mg oral MIFI and 48 hours later, 800 mcg meso. Now coming to the 5th question, a 21-year-old primee was undergoing expectant management for her incomplete miscarriage diagnosed at 8 weeks. After a fortnight of initiating expectant management, she attends for a follow-up appointment in your EPAU and informs you that she has stopped bleeding a few days ago. Now, she's incomplete miscarriage means earlier also pregnancy tissue might have been passed, or earlier also expectant or medical or surgical management was given. Now, freshly she is undergoing expectant management for her miscarriage. So now always for expectant management, you ask her to repeat UPT in 3 weeks. So already fortnight has passed after expectant management has been initiated. And now she says that she has stopped bleeding and her pain is much settled. So 15 days already passed. You can offer her a further week. Okay. And then ask her to repeat a UPT. So this comes to your mind. Now you have to search the options accordingly. Repeat pregnancy test on urine sample after 10 days looks to be a feasible answer. After 3 weeks, already a fortnight has passed. So after 3 weeks total. But from now, after 7 to 10 days, you will offer her repeat pregnancy test. Urine pregnancy test after 14 days could also have been the answer. But since a fortnight has already passed, so you will recommend pregnancy test on urine sample after 7 to 10 days. So H remains the best option. So if the resolution of bleeding and pain indicate that the miscarriage has completed, then provide the woman or person with a UPT to carry out at home 3 weeks after their miscarriage. For medical management, we use single dose meso 600 mcg. MIFI is not to be offered in incomplete miscarriage. If she opts for medical management also, then ask her to carry out UPT again at 3 weeks after the medical management. Now let's come to the next set of questions. Here we have to choose from the option list the single most appropriate management or diagnosis. Again, woman complaint of PV spotting, pervaginal spotting. She is not sure of her dates. UPT is positive. Ultrasound has been done. Okay, did not show any intrauterine gestational sac. No adnexal mass. Have minimal free fluid. What is your next management? So here, we are not sure where the gestational sac is, neither intrauterine nor adnexal mass. So next, we will look at the patient's symptoms, and also a blood test, that is beta HCG, is important. So here our next management step will be beta HCG. Serial beta HCG we may need to carry out, as we discussed, for pregnancy of unknown location, to know the direction in which the pregnancy is going. We take the help of beta HCG. So here beta HCG would be the best answer. So take 2 serum beta HCG measurements as near as possible to 48 hours apart to determine subsequent management of POL. Coming to the next question, a case of medical abortion. Telephone came to midwife 72 hours later after she took medical abortion, complaining of passing out clots but now reducing. She has lower abdominal cramps and diarrhea. So what should be the advice? So ideally, in medical abortion, we give and then we wait and watch. So here, since already only 72 hours have passed, she is passing clots, which is now reducing. Lower abdominal cramps and diarrhea are the things which any woman should expect during her medical management. She should be counseled and reassured about that. So our best advice would be to reassure and repeat UPT in 2 to 3 weeks. So inform women receiving medical management what to expect, including pain, diarrhea, vomiting, and repeat UPT 3 weeks after the medical management. If in case it comes positive 3 weeks after the medical management, then she has to return for further workup to rule out any retained pregnancy tissue, molar or ectopic. Coming to the 8th question, woman came to emergency complaining of pervaginal bleed, UPT positive, ultrasound showed fetal pole CRL 4 mm, no fetal heart seen. So diagnosis again here would be pregnancy of unknown viability because CRL is 4 mm. 4 mm means it has not reached 7 mm yet. So we can't be sure of the viability. If we are unsure, it becomes pregnancy of unknown viability, as we already discussed. So we see that diagnosis of miscarriage using single scan can't be guaranteed to be 100% accurate because there is a small chance that the diagnosis may be incorrect. So unless and until we have reached 7 mm, we can't be very sure of the diagnosis. Even if first scan is at CRL more than 7 mm with no heartbeat, still we have to perform a second scan 7 days after, or a second opinion is to be taken. Coming to the second last EMQ. Choose the appropriate answer from the given options. Investigation after 3 first trimester recurrent pregnancy losses. So here, recurrent pregnancy loss, the question is simple, but we have to choose the correct set of investigations, which includes all of them, which are relevant. Also, unnecessary tests we have to exclude. APLA, cytogenetic analysis on pregnancy tissue, parental peripheral karyotyping. Parental peripheral karyotyping is not necessary unless and until this comes out to be positive. So D is excluded. E seems to be the best answer because HLA, cytokine, all these are not much required. Similarly, factor 5th lead-in, prothrombin gene mutation are not much required, and that also, especially in first trimester, not required. So E seems to be the best answer. So here, initial summary of recurrent miscarriage, we find everything. Acquired thrombophilia, that is APLA, this should be offered. Second trimester miscarriage, women may be offered testing for these, but still they are within a research context only, unless and until other factors are there. Also, cytogenetic analysis should be offered on pregnancy tissue of third and subsequent miscarriage and in any second trimester miscarriage. Parental peripheral blood karyotyping, in whom testing of pregnancy tissue reports an unbalanced structural chromosomal abnormality, then only parental karyotyping is to be performed. Also, 3D ultrasound is the gold standard for assessment for congenital uterine anomalies, and thyroid function tests and assessment for TPO antibodies. So these are the best set of tests which are offered. Last one, investigation after RPL and with history of DVT after using COC pills. History of DVT after using COC pills. That means somewhere she is at high risk of inherited thrombophilias. So it is necessary that we carry out a test. Besides APLA, we need to carry her out for congenital thrombophilias also. Inherited thrombophilias. So additional to this, routine tests, factor V lead and prothrombin gene mutation, these tests might also need to be carried out. So the best option is G. Thrombophilia testing to be done along with routine testing. These are established causes of systemic thrombosis. Okay. So since they are established causes of systemic thrombosis, we need to rule out that. Because in general, after COC pills, nobody gets spontaneous DVT unless and until some risk factors are there. So since we suspect risk factors, so we need to carry out these tests. So in this, the best answer becomes G. Okay. So this was all regarding the 2024 questions which have been asked in early pregnancy based on the early pregnancy module. Hope it is helpful for you all. All the very best to all of you. Keep on learning, keep on preparing well. Hope it is helpful. Thank you.